Great, and I will say good morning, everybody. Today is the 24th of July, 2020. We're in the middle of coronavirus, probably the storm of COVID in South Africa. I think we crossed the unfortunate milestone of having just over 400,000 cases of coronavirus in South Africa, and I think we are now the 5th country in the world after the US, US, Brazil, Russia, India. Have I missed someone out? So tough time, but it's lovely for us to have Alex Zumazuma, who in fact is a registrar from Malawi, and Alex is zooming in from Malawi because he got stuck there because of coronavirus. Very keen to come back, I know, Alex, and we're very keen to have you back. And Alex agreed to talk today at our divisional seminar about intellectual disability and child and adolescent mental health services in Malawi. And I think that will be a really useful talk for us. The earlier parts are relevant to all of us, and I think it'd be really interesting for us just to hear your thoughts about services in Malawi. So with that, I'm going to hand straight over to you, Alex. We hope for the best for internet connectivity and so on. But at least I think we've made a good start. So I'm going to thank you for your presentation, and we'll let you present, and then we'll do discussion at the end of
it. Thanks, Prof. As he has already said, today's discussion will be on the intellectual disability and the child and adolescent mental health services in Malawi. I'm hoping that it will be more of a discussion than myself presenting, because I'm hoping that I'm going to learn more from you guys and probably help me with setting up the facilities in Malawi. So I know that probably every participant for this Zoom meeting know about a certain family. I was the 2 months I was at DICAP, I was the case manager. So for the sake of confidentiality, I decided to call this family the Queen and the 3 Musketeers. So it was a family of 3 kids. The diagnosis, we are thinking, could this be intellectual disability or specific learning disability? And also these kids had some other comorbid neurodevelopmental disorders. Their history is not these kids they dropped out of school, and the time I was seeing them, it was almost 2 years after presenting to mental health facility. The Western Cape Education Department was involved, but there was lots of follow-up and placement. And when I was thinking about this presentation, I was also thinking about the Queen, which is the mother for the kids. What was the burden for this child? I mean, this caregiver, the time she was coming to dig up, because every day I would see her outside the garden, the money she was spending to travel back and forth, the stress and the anxieties. And I was also thinking of the kids, what was their future on the socio-economic aspect? Are they going to live a normal and independent life? So this is just a brief about the kids. I think most of you were also involved in these kids. So I hope you, as we are presenting, we have to be thinking about this family. And the question would be why should we be discussing about intellectual disability? One of my resources was with the Western Cape Forum for Intellectual Disability, and there is an interesting piece of article. And what they said in the article was that all children have the immediate right to education in terms of Constitution of the Republic of South Africa, which was amended in 1996. But the Department of Basic Education has not been including over 500,000 learners with disabilities from school. That was the report from 2015. And we had to take the case to High Court, which ruled out that these people have been, their lives have been violated for quite some time. And you might be saying why are you only giving reference for South Africa? We also have cases in Malawi. And in our Constitution, under the Disability Act of 2012, they tried to define disability as a long-term physical, mental, intellectual, or sensory impairment, which in interaction with various barriers may hinder the full and active participation in society for a person on equal basis with other persons. The picture which I'm showing you is of a child with disabilities, and there's another gentleman on the picture. This is what what we usually see on our streets. People usually abuse these people. They take them as a business. They'll take the kids to the streets, start begging money, but these kids, they never take any share of the monies. We also have cases where people are subjected to traditional healers and all sorts of abuse. So for this presentation, I would say it has two parts. The first part is more of the academic part, just trying to remind ourselves what intellectual disability is. So we'll look at the epidemiology, the diagnosis, management, and after that, we are going to briefly discuss the child and adolescent mental health services in Malawi and the way forward and recommendations. So probably if I'm to ask anyone in this Zoom meeting, everyone is going to give us a different definition of what intellectual disability is. And on this slide, as you can see, I've only managed to get 3 definitions from the WHO and ED, which is the American Association of Intellectual Disability and Disorders, and the World Psychiatric Association. The WHO and the ED definitions they are a bit similar, but the World Psychiatric Association they define intellectual disability as a syndromic grouping or meta syndrome analogous to construct of dementia, which is characterized by deficit in cognitive functioning prior to the acquisition of skills through learning. We have a lot of definitions from international ICF and other bodies which deals with intellectual disability. But when we are talking about intellectual disabilities, usually the ID has 2 core symptoms, and usually these are the low intellectual functioning. And when we say that someone has a low IQ, we're talking about IQ of less than 70, and the other symptom is the impairment in adaptive functioning. And using the IQ as a marker for intellectual disability, we can group the ID into mild ID, which is IQ of 50 to 60, moderate, severe, and profound. Profound is the IQ of 0 to 20. And in this group of ID, we also have people with borderline intellectual functioning. So these are the people who have the IQ of 70 to 80. This slide is basically just trying to show us and inform us on what things do these people achieve, or what things can they attain according to their degree of intellectual disability using the IQ. It's ordinary people, as you can see, ordinary people with mild and moderate, they are able to attain some of the skills like literacy and self-help, but people with severe and profound, most of them cannot even attain or be able to develop speech skills. And probably the psychologist would be interested in this, because you have the guys who are mostly involved in assessing the IQ. And I know that you use lots of tools like the Whiskey, Stanford, and lots of things, and other tools which you have at your disposal. But basically, this is also a picture which is also depicting how the IQ are distributed. So we are saying that between 70 and 80, this is the borderline, and below this is where we have the mild, moderate, and severe. But not always do we have the tools, and as clinicians, we can also try to estimate the IQ of our clients. And in the absence of tools, we can use the rough estimate of IQ, which is usually measured using the developmental age, divide by the chronological age, and times we have to multiply the figure by 100. So this is just a rough estimate of how we can do the IQ measurement without the appropriate tools. So if we are to the other question would be like, why are we really discussing about intellectual disability? I think it's good and best that we are discussing about intellectual disability because the prevalence of ID is a lot. Like as you can see, like in the general population, almost 1 to 3% have intellectual disability, and to compare like the females and males, it seems that males are more prone to develop intellectual disability, and also the incidence of and prevalence of intellectual disability is high in the low and middle income countries. As you can see, like the ratio is 1 to 2. South Africa and Malawi, we are all in the low and middle income countries, and these figures might be attributed to other factors like nutrition, infections, and many other things. I think we'll discuss at the end. And when we are talking about like the etiological factors for intellectual disability, we have like a lot of factors. We have the genetic factors, prenatal illnesses and issues, childhood illnesses and injuries, and environmental factors. If you look at this table, you would see that like in our setting, like African setting, most people are prone to get these things like meningitis, neglect in infancy, malnutrition, abuse, and all other things. This pie chart is just summarizing what I've already discussed about the etiological factors. From my 2 months experience working at DICAP, I would say that like not only do people with intellectual disabilities have like a VID on its own, but these people they also present with lots of psychiatric and medical comorbidities. For example, the psychiatric comorbidities, which is in almost 50% of our clients, these kids have like anxiety, ODD, autism. Others have ADHD, depression, and conduct problems. And if we are to do like the genetic testing, like these people would also have things like Fragile X and others. And on the medical comorbidities, there is things like epilepsy, cerebral palsy, and also sensory issues are more common. This is also just trying to summarize like some of the conditions which are associated with intellectual disability. So we have Down syndrome, others call it like trisomy 21, and the picture on your right is just trying to show some of the symptoms for Down syndrome. Of interest, you might notice that like the phenylketonuria is more prevalent in Turkey than China. This is because this condition is associated with people who marry their cousins. So in Turkey is a Muslim country, and mostly people would marry their cousins. And this condition is a recessive. For someone to get like a phenylketonuria, they have to have like mutations from both the parents, like the mom and the father. So that's why like we have more cases of phenylketonuria in Turkey than in China. And we also have like things like congenital hypothyroidism and fetal alcohol syndrome. So the question is like, how do we usually make the diagnosis of intellectual disability? Usually for us to say that like someone has intellectual disability, their IQ has to be below 70. They also have to have impairment of adaptive functioning, and also the onset has to be before the age of 18. And usually before we can make a diagnosis, we have to have a chat with the family, try to understand the family medical history. We have to understand all the predisposing factors during pregnancy, developmental period, and the environment of your home. And we also have to do a physical examination to rule out other medical comorbidities. And as I've said, we can also do like some labs and genetic testing. For the sake of this presentation, I want to got the DSM-5 criteria. So DSM-5 criteria, I'd say like for me, is one of the easiest way for classification of disorders. And basically what we are saying that like for someone to have a diagnosis of ID, they have to meet the three criteria. They have to have the deficit in intellectual functioning, such as reasoning, problem solving, planning, abstract thinking, and others. And also they have to have deficit in adaptive functioning that result in failure to meet developmental and social cultural standards for a person's independence and social responsibility. And the onset of the intellectual and adaptive deficit has to start during the developmental period. If you go further like, to study like the DSM-5, they also describe ID using specifiers, and the specifiers which they use in DSM-5 allows clinicians and health workers to classify ID as a mild, moderate, severe, and profound by not using the IQ scores. So the various levels of severity are defined on the basis of adaptive functioning and not IQ scores, as we have seen on the previous slides. I decided to put this slide just to show what other countries do and how they also do the screening for ID. So in high-income countries, they have like the screening tool, the HILPIC test, and this is done within the first 48 to 72 hours of birth, and usually like the test is able to screen for phenylketonuria, primary congenital hypothyroidism, and cystic fibrosis. I'm not sure if South Africa is able to do this, but in terms of Malawi, we are unable to do like most of the tests, including this one. So when we talk about ID, people would only maybe think about ID with other psychiatric comorbidities, maybe because we are psychiatrists or psychologists, but we always also have to think of like the medical differential diagnosis. We have to think about deafness, poor eyesight problems, and we also have to be able to get a good history to identify underlying causes of ID, especially those which are reversible, like cerebral malaria, neurological disorders like epilepsy, hypothyroidism. And we also have to always discuss with the families and discuss with them the risk of marrying cousins like from the same family. And when we have clients who have a sudden regression in their IQ, then that has to be taken as a medical emergency. As per previous said, like ID has many psychiatric comorbidities, but we also have to think of other differential diagnosis. So things like severe understimulation, abuse, or neglect that can also present as ID, specific learning disabilities and communication disorders, things like autism, and also major and mild neurocognitive disorders. In case this can present as ID, so we have to have the skills to be able to differentiate ID from all these conditions. We all know that, like, and from our experiences, that kids don't present to the hospital by themselves. They always have like a caregiver, and whatever kids are going through also affect their guardians. So we have always to check the mental health issues for the parents. We have to understand how they are coping, and also have to screen for depression in mothers, because this is one of the common things for parents taking care of people with ID. We also have to check for domestic violence, recent divorce, and we also have to check for child abuse or neglect, severe bullying or exclusion by peers, and also severe deprivation or poverty. So when we have kids with ID, what do we usually aim for, like in our treatment? Usually we aim for treatment for people with ID is first to identify and treat the reversible causes of ID. Second is to alleviate suffering for child and the family, and also to promote healthy development towards greatest possible independence. So the treatments which are available, so we say like first we have to find the etiological treatment because it's non-treatable things like phenylketonuria and hypothyroidism. Other treatment involves parent skills training, behavior intervention for challenging behavior, psychoeducation, and community-based rehabilitation. And this slide is just some on the family education. We also have to involve teachers. We have to advise them how best they can take care of his kids in schools. And also we have to manage the hearing and vision problems if they have, and also manage other medical comorbidities like epilepsy. When I was preparing this presentation, I was trying to find the parent skills training in low and middle income settings, which from what I got, like WHO is trying to test how effective this can be in our setting, but I didn't manage to get any good evidence towards it. Usually, I would say like that was even myself before I did like a 2 months training at DIGAP. I would think that every problem, like every psychiatric problem, I have to treat it with medication. But staying at DIGAP for 2 months, I'd say that like somehow how I think about medication is different prior to my stay at DIGAP. And in case of ID, there isn't much evidence when it comes to effective of medication. And only can we use medication after we have done a comprehensive assessment and also in combination of psychosocial treatment. Antipsychotics sometimes are useful in crisis situations, but they only have to be used in short term, and we always have to start slow. And people with other comorbid psychiatric illnesses like depression and ADHD, then we can use the medications which are prescribed for ADHD or other psychiatric comorbidities. But when it comes to ID on its own, there isn't much evidence when it comes to medication. So having presented like on the general intellectual disability, I would now discuss about the child and adolescent mental health services in Malawi. And the picture you have in front of you is, I would say, like the reality for almost 70% of Malawians. Almost 80% of Malawians live in the rural areas, and only 20% live in the urban settings. So Malawi as a country, we have a population of 18 million, and school age children, which is the age of 5 to 19, are only almost 40% of the total population, and more than 6% of children in Malawi are still not attending primary school. And for those who go or who start primary school, only 59% they are able to finish the first 4 years of their school. And out of 150, 152 out of 100 women aged between 15 and 19 years of age have a child. And 1 in 4 children in Malawi is involved in child labor. The picture on the screen, this is like a place in Malawi called Kasungu. This is where we do like most of our tobacco farming. and that's where most of the child labor is done. And 46% of girls are married before the age of 18 and 9% before the age of 15. 65% of girls and 35% of boys experience child abuse in their lifetime. So if you are to recall like, the first part of the presentation when we are discussing about various factors for intellectual disabilities, you can see that in the case of Malawi, we have lots of children who are at risk of developing intellectual disabilities and other psychiatric conditions. And also of note is that 29% of adolescents between the age of 15 and 19 have begun childbearing, bearing children, and 23% of all children cases in Malawi are related to undernutrition. And 12% of babies are born with low birth weight. This picture is of Madonna, the pop artist. She's involved in most of the charity work in Malawi, and a few years ago, she also managed to donate for funds for a child and adolescent hospital, but this is mainly for surgical operations. And she also adopted 3 Malawian kids. So how do we provide like services for child and adolescent mental services in Malawi? Unfortunately, there are no established child and adolescent services in Malawi. There's one facility in Lilongwe, which is the capital city of Malawi. It's called St. John of God. They have people who attend to adolescent and children, but this is a private facility, and most of Malawians cannot afford to go to this facility. And when it comes to government hospitals, there are no specific clinics. We see kids with adults together. And in our setting, like people who provide these services, like the mental health services, is mainly the mental health nurses. So these are people who, after high school, they go to do 3 years of training. And we also have clinical officers. These have diplomas in medical training, and during their training, they are only trained. During their 3 years of training, they only undergo 4 weeks of psychiatric training, and during their 1 year of internship, there is no psychiatric rotation. And we have medical doctors, 6 years of training, and only 6 weeks of psychiatry during their undergrad. And during their 8-month period of internship, there is no psychiatric rotation. And I would say currently we have 3 trained psychiatrists who are practicing in Malawi. Some of the psychiatrists, I'll say we have like guys from the UK who would come on voluntary basis. But for Malawians, we only have like 3 trained psychiatrists. And the psychologists, we have only 4 psychologists which are practicing in Malawi. So you can see that we are talking about intellectual disability, having the knowledge to rule out other psychiatric comorbidities, but most of our health workers are unable to identify like ID, even other comorbidities. When talking about ID, people talk about the IQ test, all those things, but we only have 4 psychologists in the whole of Malawi to cater for 18 million people. So what are the challenges we usually have in Malawi? As I've already said, like the first one is lack of knowledge and skills to do developmental assessment. Most clinicians, even nurses, they are unable to do developmental assessment. They are unable to understand other psychiatric comorbidities, and for them to exclude them is also a challenge. Simple things like I would say, now I can say simple things, but things like a snap, scale, and all those screening tools, most of the people, they don't know that these things exist. And we can also talk about medication. We don't have medications like Ritalin, even the spreadon itself, like the availability is not stable. Also, when I was preparing this presentation, I also had a chat with people from the Ministry of Health to see if they have any protocols or guidelines for child and adolescent mental health. Unfortunately, we don't have all those protocols. And as I've said already, that there are no centers or special schools for kids with intellectual disability. The past few months have been in Malawi. I've been having supervision now with John Joe. And during one of our discussions on the ID, we also managed to talk to Okat, who is a clinical psychologist at Alexandra Hospital, on the use of a psychometric test in Africa. So this slide is basically like the discussion we had, and her comments was, if only we can get a psychometric talisman to ward off some of the societal evils that so many children with ID face each day. And she further explained that brief screening instruments such as 10-question questionnaire and Wessex behavior scales tend to have poor psychometric properties when used locally. Clinicians and researchers have endured to find a brief screening instrument with high fidelity in our context, but substantial challenges remain. And the use of instruments such as binary adaptive scales or adaptive behavior scales is challenging when working with children and others in Southern Africa. And when working with children from disadvantaged social economic backgrounds, some of the items require access to resources that are quite frankly not available, readily accessible, or culturally appropriate. And also, I found this paper an interesting paper. This was published by Judith Annie. The paper was discussing the intellectual disability in Africa, the implications for research and development. And on their paper, the implications were that service provision for people with intellectual disabilities in Africa is not always well served by insight obtained from Western research agendas. Appropriate and effective rehabilitation requires an understanding of the context and the environment in which the disabled person operates. And ingenious research into provision of support to families and inclusion of persons with intellectual disability into mainstream programs, as well as disability-specific provisions are recommended. So having discussed about ID, showing you like how poor we are in Malawi, that we don't have most of the services, what would be the way forward? I didn't have like much to write on the way forward, but on the questions, which I'm hoping that people might even help me with answers. One of the questions was, how can we increase and speed up access of mental health services and special schools for people with ID? I would say this is not only for the case of Malawi, the Queen and the Three Musketeers, I'm saying they spent like over 2 years trying to follow up with Western Cape Education Department. And also, after presenting the discussion I had with OCAT and the other paper, like the question would be, have psychometric tests proven to be effective and reliable in African context? And the other question I had is intellectual disability a psychiatric condition or a socio-economic condition? How can we ensure that people with ID are able to attend and enjoy the basic needs and live an independent life? The last question I had, are we doing enough for these people? So part of the recommendations, I'm saying that I got this from WHO, which have so we have on the recommendations, like as I've said, like I got this from WHO, and what they recommend is first we have to prevent the ID. So we have like the primary prevention, things like infections, immunization, and when we find people with ID, we also have to make sure that we provide or stop the progression of disease, and also the tertiary part, like supporting the families, training and vocational opportunities, of which I would say like most of African countries, we are unable to provide the secondary and tertiary services. The other recommendation would be that we have to train teachers to identify those with learning disabilities or learning difficulties early, that they can be referred to professionals who can make a thorough assessment and refer this patient to appropriate institutions. And we also have to train parents on how best we can identify people with ID and also support kids with ID. In the case of Malawi, I would say that all medical professions, we have to understand the developmental assessment. Like we have to be able to do like a proper developmental assessment, that in the absence of the assessment tools or psychologists, we should be able to have a rough estimate of the IQ. And the other recommendation, I would say that we have to have special schools and rehabilitation centers. The only problem with like the special schools and rehabilitation centers, I would say like is the political will. And maybe on our part, the only thing we can do is to advocate for these people, because these people have a problem that they are unable to express themselves fully. So who is responsible? I'd say that everybody is responsible. And that marks the end of my presentation. These are the resources. Mostly the information from Malawi, I got it from Feed the Nation and UNICEF Malawi. Thanks very much.
Great. Well, let's start by giving you a round of applause, Alex. Thank you. And just two words from me before I open up for questions and comments from people. And you've said it, but it's worth just saying again. Number one, in the last month, we published, a large group of us published a paper on a number of disabilities in the world and where they are. And what the paper showed, again, was that intellectual disabilities, that 95% of people with intellectual and other developmental disabilities come from and live in low and middle income countries. 95% of the world's people with intellectual disabilities live where we are. And yet most services are in higher income countries, number one. Second thing that you said that was really important is, if you have intellectual disability, or the new term that ICD is encouraging is disorder of intellectual development, as you know, you're at much higher risk of other neurodevelopmental disorders, you're at a much higher risk of other mental health disorders, you're at a much higher risk of other physical health disorders. You gave epilepsy, but remember also dental problems, diabetes, gastrointestinal problems, obesity, all those things, and they also add to that side. And as you say, all these environmental problems are much higher risk. Family mental illness, broken families, poverty, etc., abuse. And so it really is an incredible risk factor for so many things. I don't think intellectual disability in itself is an illness or a disorder, but it's an incredible risk factor for so many other things. Just two words of comment. The WHO are very aware of these needs in low and middle income countries, and they are doing two things. One you've mentioned, and that is we are working in 33 countries now. We're evaluating this program called this Caregiver Skills Training, CST, for children with developmental disabilities. We're piloting it in South Africa. There isn't a project in Malawi at the moment, but the WHO would be very interested if there are partners in Malawi who would want to pilot this caregiver skills training. It's a group program over 12 weeks for parents of children. They don't need to have a diagnosis, but with any concern about their development. And the second thing is the WHO is also very aware of the need for measurements. And there is, in fact, a tool in Malawi called the MDAT. I don't know if you've heard of the Malawi Developmental Assessment Tool, developed by Melissa Gladstone. So there is a tool that can be used by non-experts, and the WHO is working on a global kind of a developmental screening tool to be used in low resource settings. So at least people are interested. So now I'll let you comment and we'll throw it open to questions.
Let me just comment like on the MDAT, which is the Malawi Developmental Assessment Tool.
That's right.
It's not a simple and straight tool. One of the people who developed it is the vice principal for College of Medicine, and that's what I did in my third year. But I would say it's not easy. It's complicated that most people don't even understand it. So of course it brings like the knowledge, like, and we trying to contextualize it like in our setting, but it's complicated.
And so the challenge is to make it usable, right?
Yeah, to make it usable. So
absolutely, great. So I'm going to stop recording now, Alex, and then we'll open it up to questions. So let me stop the recording.